drugs which are very important. As I told you previously, that some of these drugs you will now prescribe in your clinics. One of them is this group, because they are related with the management of blood pressure. But this is one of the problems that you will find with your many patients. You will see in your clinics visiting you that patients will be suffering from high blood pressure. So you should have an idea of these drugs. One thing. Secondly, there is possibility for interaction with the drugs that you inject, like local anesthetics to your patients while they are also suffering from hypertension. Second important thing, you will also discuss with Dr. Ayman, and maybe already discussed with Dr. Ali. Many times you will find comorbidity in such patients. As you will discuss today in your PPL case also, that gentleman is suffering from more than one disease at the same time. Like most probably hypertensive patients, they suffer from diabetes mellitus, type 2 diabetes mellitus, and there is also possibility, as what you discussed with Dr. Fathi, hypercholesterolemia. The cholesterol level is high, maybe it is LDL, maybe it is total cholesterol, or maybe it is triglycerides that you have taken in biochemistry. So lipid profile is deranged, and so they will be taking at least 3-4 drugs together. So for you it is important to understand that where we should use these drugs, or people who are using these drugs, how to manage. Now the definition that you have already taken in physiology for blood pressure, that it is CO times SVR, and you know CO stands for
Cardiac output.
cardiac output, and SVR stands for systemic
Vascular resistance.
resistance. We use mostly two terms. One, if the blood pressure is higher than normal, and the other one, if the blood pressure is low than normal. So if it is higher than normal, we say it is
Hypertension.
hypertension. And if it is low than normal, then what we say?
Hypertension.
Hypotension. Good. So HTN is hypertension, and low blood pressure is hypotension. Okay? But if the blood pressure is normal, then what we will say? Because normally this term is used, you will find patients in your clinic. They will tell you, this is layman terminology, that doctor, I have blood pressure. Like, I don't know what you say in Arabic, but for example, you have a patient and you are discussing something, the patient will tell you, not high blood pressure, he will say, I have blood pressure, isn't?
Yes.
Like sometimes patients say, I have sugar. So everyone has sugar because we need sugar for our body system, isn't? But this is layman terminology. Okay. Because if there is no blood pressure, we cannot survive we need blood pressure. But in layman terminology, blood pressure means high blood pressure, and that is hypertension. If it is low, that is hypotension. And you will mostly find these problems in your clinic. Mostly hypertension, but sometimes also hypotension, especially in females. But because you are medical students, if there is no high blood pressure, no low blood pressure, the blood pressure is normal. So how you will prescribe or describe the patient that I have a patient, so what type of patient? Because one is hypertensive, the other one is hypotensive. But if the blood pressure is normal, what is normal blood pressure?
80 to 120.
120 to
90.
80. Something less than this. mmHg. mmHg. mm stands for millimeter of mercury, because this is the distance. I don't know whether you discuss it in physiology or not yet. Yeah, I will use it. Okay. But as you see now, it is quickly being replaced with digital. So in digital there is no mercury. Mercury sphygmomanometer. This is called sphygmomanometer. The apparatus that measures the blood pressure is called sphygmomanometer. But as it is being replaced with digital, so we don't see that how the mercury travels. But if you see the mercury sphygmomanometer, you can see that the mercury is traveling up. So that is the distance that is covered by the blood. But here we have two values. One is the upper value and the other one is lower value. So we say 120 over 80 or something less than 80. That is called the normal blood pressure. So that subject will be called normotensive. Like all of you should be normotensive when the blood pressure is normal. Then it is called normotensive. Okay. Now, what time we should use these drugs? Because two things are important. You will discuss today in your PBL case also. First one, that we should take the blood pressure readings at least 3 times at 3 different times. If patient comes to your clinic and you check the blood pressure and it is high, and you say, okay, you are having high blood pressure and start this medication. This is not true or appropriate. Why? Because there is possibility, sometimes even we face anxiety when we go to the doctor. So even in anxiety, slightly the blood pressure goes up. So we need to repeat at 3 different timings. Second, we should check in both arms, left and right. That is second important thing. The third important thing is, first we will advise lifestyle modification, unless it is very high. For example, you have a patient where the blood pressure is 140 over 90 mmHg. This is hypertension. I think you also know stage 1, stage 2, stage 3 like this. This is hypertension, but this hypertension may be managed with lifestyle modifications. What is lifestyle modification? Reduce weight. If the patient is overweight, we would advise the patient start exercise, go to gym, have a walk, and start to reduce your weight. Second, say goodbye to salt. Sodium chloride, no sodium chloride in the food, although this is very difficult. More difficult than sugar. Also reduce sugar, carbohydrates, because mostly you will see these patients are overweight, obese, also suffering from type 2 diabetes mellitus. If this is failed, then the next step should be, we should introduce drugs. So the drugs that reduce the blood pressure, they are called anti-hypertensive agents, because they reduce the blood pressure. This is the common protocol. But for example, you have a patient where the blood pressure is 180 over 120 mmHg. So what you will do? Again, you will say, okay, you reduce your salt intake, or say goodbye to salt, start exercise and come after 3 months? No. Because this is high blood pressure, maybe stage 2, and it can lead to complications. So we will start with treatment. Although this is true that short-term problems with blood pressure is not that much. You will see in clinics, even last week we had a patient 220 over 170. 220 over 170, and he was relaxed. Why? Because many times there are no short-term complications. But you will see this patient maybe after 3-4 years, paralysis. You know paralysis. What is paralysis in Arabic? Maybe hemiplegia, maybe stroke. So paralysis, please check, you will find something. P-A-R-A-L-Y-S-I-S, paralysis or hemiplegia, or stroke, or myocardial infarction, or heart attack, hemiplegia. What is it? Shuttle. Yeah, so apparently he was doing fine and he said, I am feeling no problem. But someday you will find that he is paralyzed and it is irreversible. You might have seen people, and it is irreversible. So the upper value, that is called systolic, and the lower value is called diastolic. Systolic because this is the contraction of the heart. Which chambers? We have 4 chambers in the heart, or 5, or 6.
No,
4 or 5?
4.
Really? Confirm?
Yes.
4 chambers or 5?
4.
Chambers of the heart.
4.
Chamber ghurfa, huh?
Yep.
So how many ghurfa? 2 or 3 or 4?
4.
4 or 5?
4.
Really? Okay, which 4? Yes. 2 and 2. 2 on the right, 2 on the left. So right ventricle first or atrium? Atrium, then ventricle, and then left atrium, and then left ventricle. Good. 4 chambers in the heart. Okay? So when there is contraction of the ventricles, so that is called systole. So from systole, it is systolic blood pressure. SBP, systolic blood pressure. If it is the relaxation of the ventricles, that is called diastole. So then we say diastolic blood pressure. Diastolic blood pressure. So these are the 2 values. If you will find sometimes patients that it is 150 over 80 mmHg. Yes, sir. Is it normal or no?
No.
Why? because this is normal. You said that this is normal.
That's still
The systolic is high. So what we say? Yes, who is good in physiology? All of you, mashallah. Please, Yazan. You always help. Today no help. Isolated, you understand?
Yes.
Systolic blood pressure. Isolated systolic blood pressure. Although the systolic value is normal because it is 80 or maybe 85, still it is normal. But the systolic value is high. So that is called isolated systolic blood pressure. Next important thing that we need to understand, mostly we deal in our clinics with patients with essential hypertension. Essential or primary hypertension, where we don't know the exact reason for the blood pressure. Where we don't know the exact reason for the blood pressure. Essential or primary hypertension. 90% blood pressure patients, they are with essential hypertension. And mostly you will deal with patients with essential hypertension. But if some patients you will also find they are suffering to another type of hypertension. That is called secondary hypertension. Secondary. Why it is called secondary? Because the reason is known. It is due to something. So is the most important reason for secondary hypertension you discussed with Dr. Ali. It is his favorite topic. Secondary hypertension, the most common reason, and you will find these patients nowadays, unfortunately, in your clinics. They are on dialysis. Which patient is on dialysis? You know dialysis. Dialysis is done, this is the last case in renal module. The patient developed acute nephritis due to diclofenac sodium and he was on hemodialysis. So hemodialysis is done for what? When the patient is having which problem? Renal?
Failure.
Very good, failure. So renal failure or renal impairment is the most important reason for the secondary hypertension or blood pressure. Okay? You can say 5 to 6% patients or even more than that will be suffering due to secondary hypertension due to renal failure. But again, mostly you will find patients with primary or essential hypertension. Sometimes you will also find patients pulmonary hypertension due to lungs. Sometimes you will find patients with hepatic or portal hypertension. But again, mostly you will deal with your patients that will be suffering from primary or essential hypertension. And the drugs that we are discussing, they are basically for the primary or essential hypertension. Clear? And the drugs which are used to control the blood pressure, that are called antihypertensive agents. Remember, this is very difficult to bring down the higher values of blood pressure to normal even with drugs. You will see even in today's case. It is really difficult. What is important take-home message, that mostly antihypertensive medication is lifetime. Lifetime means that the patient now use for life. It is not like Fifadol or Panadol that you get headache, you use it for 3-4 days, khalas. It is not your throat infection that you get and you get some antibiotics or some other medication and it is gone. It is not cough. This is lifetime. So we should be thinking about this, that even with medications, and you will see polypharmacy, the patient will be using more than one medication alone to control blood pressure. Forget about hypercholesteremia, hypertriglyceridemia, blah, blah, blah. Alone to control blood pressure, you will see in your clinics that they will show you, doctor, I'm using these 4 or 5 medications only to control blood pressure. So you can understand how serious is this problem. Clear? Okay. Now we have this very busy slide. Blood pressure is the cardiac output into systemic vascular resistance. As you know from your physiology, cardiovascular system is composed of 3 components. Cardiovascular system is composed of 3 components. Our module is based on these 3 components. First component, you understand component, juz. The first component of the cardiovascular system is heart, very good. Second component, sorry, veins only.
Arteries.
So together what they are called? Yes, you know it. Just try to focus. BV. What is BV? Yes? Blood vessels, mashallah. Who said blood vessels? Who said? Okay, mashallah. Blood vessels. The third component, capillaries are blood vessels. Veins are blood vessels. Arteries are blood vessels. Aorta is blood vessels. Arterioles are blood vessels. Venules are blood vessels. The third component. Huh? Lungs. The component of the cardiovascular system, mashallah, you are smart. The blood goes to the lungs, but that is not component of the cardiovascular system. The blood goes to the lungs through veins and arteries. We receive and send different system, you understand. But there is another component, because without that these 2 components are useless. Bone marrow. Bone marrow produces what? Blood. Very good. Third component of the cardiovascular system is blood. And blood is again divided into 2 components. Plasma and RBCs and platelets. Very good. Plasma and the formed elements, these are called formed elements. RBCs are erythrocytes, WBCs, white blood cells, are leukocytes, and the third one are platelets, are thrombocytes. Good. So, heart, blood vessels, and blood. Because if there is no blood, what the heart will do? Because heart pumps blood, whether it is oxygenated or whether it receives deoxygenated, sends it to the lungs and bring back the oxygenated and sends through left ventricle, aorta, and arteries, arterioles to circulate throughout the body. Good. Now, cardiac output. The second thing is systemic vascular resistance. What do we mean by systemic vascular resistance? Systemic vascular resistance means the resistance that is offered by the blood vessels. The resistance that is offered by the blood vessels. So the maximum resistance is offered to the blood by aorta. So the pressure is more. The pressure is more. It is like washing car. You see, they use hose. So more pressure is due. So the pressure in the aorta is more. Why? Because it needs to push the blood throughout the body. When it comes to the veins, it is even sometimes minus. So low pressure. So this is called systemic vascular resistance. Okay, we need to have two things. One, cardiac output, and the second one is systemic vascular resistance. So if there is vasoconstriction, the blood pressure will be high or low?
High.
High, very good. Why? Because you reduce the diameter or the radius. If you relax the blood vessels, there is vasodilation, the blood pressure will be low. Okay, this is one thing. But the second part is also important, and that is cardiac output. So how do we calculate cardiac output? Who will help me? Because it is more important sometimes in your clinics that the patient heart beats more fast, because cardiac output CO equals to human resources into SV. HR is human resources?
No.
No?
Heart
Heart rate, very good. And SV,
Stroke.
stroke volume, so cardiac output is equal to HR and SV. So HR is how much?
60.
60, yeah. Oh, you are athlete? 35. Big athlete, huh?
70.
70. Very good. 72 for you, you are young. 72 minutes beats per minute. SV, stroke volume, how much?
5 is.
5 liters.
No. Also
Same?
yes.
70 milliliters.
Very good. 70 mil per minute. Minute is cancelled with minute. So how much it will be? 72 times 70. Who will help me? 0. Calculate.
4,800.
Yeah, those.
Almost 5.
No, exact value. Tell me exact.
4,090.
4,090?
900.
Why? 900. You don't take your calculator.
513.
550, I think.
530.
530.
I think.
Just a minute. 0, 7 दूनी 14, 7 7 49, 50. 5040. Check it.
Yes.
5040. So that is milliliter. And how we will convert it into liters? Easy. So 5.04 liter. And this is the cardiac output, and this is the blood volume in our body. Our body has this much blood volume. So it depends on the stroke volume and your heart rate. So if your heart beats faster, the blood volume and the cardiac output may be more. If it beats slower, like in athletes, sportsmen, so the blood volume may be less. Similarly, in females, slightly less as compared to males. Okay, good. So, this is the blood volume or cardiac output. Now you see, cardiac output is again cardiac factors, heart rate and contractibility. Heart rate we discussed, and contractibility also we discussed. But who controls the contraction of the heart. There is some activity in the heart. What is that called?
Say note.
SA nodes, very good. Electrical activity. They control SA node, AV node, Purkinje fibers, pacemakers. They control the contraction of the heart. So, first thing is heart rate. Second one is the stroke volume contraction of the heart. So, that is the contractility. Okay, contractibility, that is based on the electrical activity. Thank you. Okay, now the drugs that will act on the cardiac factors, the first thing before this, you will see, as you see in this table, there are drugs, they will be working by more than one mechanism. They will be working by more than one mechanism. There are few drugs that only work by one mechanism. Now, in this case, the first group that interferes with the heart rate and contractibility is beta blockers. You remember from your general pharmacology and physiology. Beta blockers. These are the drugs that block the beta receptors, beta 1 and beta 2 receptors. Ideally, we want that they should block beta 1 receptors. Beta 1 receptors, they are present mostly in the heart, very good. And some of them, they are also present in the kidneys. Also in some other parts, but majority, you can say up to 90% they are present in the heart. 7 to 8% they are present in the kidneys and others in other areas. So, what they will do? Beta blockers, they will block what? When we block the beta receptors, for example, we block the beta receptors in the heart, we say there is blockade of beta 1 receptors. So what is blocked? Like you say, you are coming to the university, there is exam and you reach late. You say blocked. What is blocked? Road was blocked, isn't it?
Yeah.
So what is blocked here? The heart is blocked, the blood vessels are blocked. Who is blocked? Valves. So you want to kill? Khalas. No tricuspid, no bicuspid. Huh? Go to Jannah. Yes.
Robert
No, but what is blocked? Low heart rate, we get it when we block. But what we block?
The receptor?
Sorry?
The receptor?
But what are on the receptors? Who stimulate receptors? Please help me. Who stimulate sympathetic receptors?
5HT4?
Yeah. So 5H24 is coming from where?
From heart.
Normally 5HT4. You are talking about prokinetics. That will lead to arrhythmias. We don't want arrhythmias. Naturally, like you are sitting now, your sympathetic system, you are sitting for your BMS exam, and you look at the paper, biochemistry exam is difficult. So what happens? Your heart starts to beat faster. So why it is beating fast? Acetylcholine?
No,
Catecholamine, what catecholamine?
adrenaline?
Adrenaline and noradrenaline. Adrenaline and noradrenaline. So what we block? Catecholamine or adrenaline and noradrenaline, even dopamine. So we block them to attach to its receptors. We block them to attach to its receptors. Why? Because stimulation of beta 1 receptors means increase in heart rate. Blockade of the beta receptor means decrease in heart rate. Why? Because you block the neurotransmitter adrenaline and noradrenaline, that is responsible for the stimulation of the heart rate. That is responsible for the excitability of the heart, the electrical activity. So that is the function of the beta blockers. We block adrenaline to bind to its receptors. We block adrenaline to bind to its receptors. Okay, good. Thank you, mashallah. Now, next is calcium channel blockers. Calcium channel blockers. Calcium is what?
Mineral.
Huh?
Mineral.
Mineral, electrolyte. Anions and cations, you discussed, I know. Yeah, so calcium is very important in the cells and muscles for contraction. Contraction of the muscles or contraction of the cells, calcium plays important role. So if you block the calcium channels, the calcium to bind to its channels, what will happen?
No contraction.
So no contraction means
No bombing.
relaxation. Relaxation. So they will cause relaxation of the muscles and cells. And relaxation means
Dilation.
vasodilation. Vasodilation. So they are called calcium channel blockers. We will discuss them inshallah in coming slides, but here just briefly. Next is centrally acting adrenergics. Centrally. Centrally means that they will act in the CNS. They will act in the CNS. Alpha 2.
treat high blood pressure.
Sorry?
To treat high blood pressure.
To treat high blood pressure. Centrally acting adrenergics. They will act in the CNS and block the hyperactivity or sympathetic activity in the brain. They will send signal from the brain, don't increase the blood pressure. So they are called centrally acting. Normally we don't use them because they have many side effects. One of them is excessive drowsiness. If someone is using centrally acting, and you see, I told you they are used for a lifetime, so he will be sleepy all the time. So that is really difficult. We like sleep, but not that much, isn't it? Okay, so that is important. Next is circulating volume. As we discussed, stroke volume are the amount of the blood that is circulated is 5 liters. That is circulating in our body all the time. And 20% of it is present in, all the time, 20% of the blood that is circulated in the body is present in which organ?
Brain?
Brain? 20%. Kidneys. 20% of the blood is always present in kidneys. I think you will discuss something like this in physiology, GFR 81, 80, some calculations, 3 liter plasma. So 20% of the blood is always present in the kidneys. So that is the circulating volume. In circulating volume, we have 2 things. One is salt, and the other one is aldosterone. Salt. Which salt? As we discussed in the beginning, sodium chloride, table salt. Sodium chloride. Sodium goes, who goes? Water goes. Sodium retains, water retains. So sodium goes, water goes, volume goes down. Sodium retains, water retains, volume goes up. Blood pressure. So that is, as we will discuss in diuretics, that how we manage or reduce the blood pressure by using diuretics. Why? Because they take away the sodium chloride from the body. And when sodium is going, water is going. And potassium is also going, but that is different story. Here, our focus is on salt and how we manage with the salt. Second important thing is aldosterone. Aldosterone, as we will see, is very important mineralocorticoid, steroid. It is a steroid. Mineralocorticoid. What do we mean by mineralocorticoid? It is a hormone that regulates minerals in our body. So like sodium, potassium, magnesium, calcium, all of them, they are regulated by mineralocorticoids. And one of the mineralocorticoid is aldosterone. And if you remember, we discussed in diuretics, aldosterone antagonists, they act on the collecting duct in the nephron. The last portion of the nephron, the last segment of the nephron. We start from proximal, then loop of Henle, then distal, and then
Collecting.
collecting duct. Collecting duct where we block the aldosterone. Why we block aldosterone? Why? Because aldosterone promotes the reabsorption of sodium and water. It promotes the reabsorption of sodium and water. That means it causes increase in volume. So that is aldosterone. Now let us see first group, ACE inhibitors. ACE inhibitors. ACE stands for angiotensin
Converting enzyme.
converting enzyme inhibitors. And as mashallah, all of you like to travel a lot, there is a city when you go from here to Qasim, Arras. And this is Ras. What is Ras? R is for Riyadh, A for Abha, the other A for Al-Baha, and S for which city with S in Saudi Arabia? Sakaka, yes. So, Ras, renin, next, angiotensin, next, aldosterone system, renin, angiotensin, aldosterone system, because they regulate the blood pressure. Renin, as the name indicates, it comes from renin. Re means, ren means renal, kidneys. So, this is the hormone that is secreted from the kidneys in response to low blood pressure. Naturally, like all of us are sitting and our blood pressure is going down. So what happens? The signal goes to the kidneys, to the renin, blood pressure is going down. So renin is started to produce. It will go and it will act in the lungs on the angiotensinogen. Angiotensin. Angio means vessels. Tensin means pressure. Because this enzyme is related with pressure of the blood vessel. So what happens? Angiotensinogen, so yes,
Lower the blood pressure.
yes. Angiotensinogen is converted or stimulated to angiotensin. Angiotensin 1. Angiotensin 1 is converted into angiotensin 2. Conversion of angiotensin 1 into 2 is done by ACE, angiotensin converting enzyme, or what we say kinase enzyme. If you ask Dr. Fatih, he will say kinase. But in pharmacology and physiology, we say angiotensin converting enzyme. Now, try to understand the difference. Angiotensin 1 is vasodilator. It is vasodilator. Angiotensin 2 is vasoconstrictor. What I told, if your blood pressure is going down, renin will get signal. It will stimulate the angiotensinogen. Angiotensinogen will be converted into angiotensin 1. Angiotensin 1 will be converted into angiotensin 2, and the blood pressure goes up. Why? Because angiotensin 2 is vasoconstrictor. So, what we do, we block this enzyme. We block this enzyme. So, angiotensin 1 is not converted into angiotensin 2. So, when angiotensin 2 is not produced, what will happen? Angiotensin 1 level is increased. So, angiotensin 1 will cause vasodilation. It will cause vasodilation, and it is part of the renin, angiotensin, aldosterone system. And we discussed aldosterone is the hormone or steroid that promotes reabsorption of sodium and water from the collecting duct. Clear? So these how they regulate the blood pressure. So we will block the enzyme that is responsible for the conversion of angiotensin 1 into angiotensin 2. Was both? Okay. The next group is diuretics. Diuretics, we will discuss them in detail. Here just briefly, as we discussed even previously, they will block the sodium chloride to be absorbed from the nephron, whether it is in proximal, whether it is in loop of Henle, whether it is in distal, or whether it is in collecting duct. So, in any segment of the nephron, they will block the sodium chloride and water. So, when we block this, what will happen? The urine production is increased. Urine production is increased. So, more urination, the volume is going down. So, that is the mechanism by which it will reduce the blood pressure. Okay. Now, the next group you see, systemic vascular resistance. In systemic vascular resistance, we have hormones, vasodilators and vasoconstrictors. Vasodilators, prostaglandins, ACE inhibitors, calcium channel blockers, and angiotensin 2 blockers. Angiotensin 2 blockers. We discussed the rest of them, ACE inhibitors, calcium channel blockers. This is another thing that they say, and it is true, that angiotensin 2 can be produced by some other mechanisms. You block one mechanism. Like when you come to the university, this is the famous road that is going from here to Azizia. But if it is blocked, you take another road and you reach to the university. Similarly, you block the conversion of angiotensin 1 into angiotensin 2. But the body uses another mechanism to produce angiotensin 2. So, people like Dr. Fatih, they are more smart to bring you difficult questions. What they do? Now they say, okay, the body is still producing angiotensin 2. When the body is still producing angiotensin 2, it means the blood pressure is going up. So they block even angiotensin 2 is produced, but now they block to attach to its receptors. It is like you come from anywhere, when you reach to the gate, you are not allowed to enter. You came from different way, this road was blocked. You took another road, maybe Tariq Dairi 4. But when you reach to the gate here, again it is closed. So the same we do. The body produces angiotensin 2 by another mechanism. We have drugs that are called ARBs, angiotensin receptor blockers. We block angiotensin to attach angiotensin 2 to attach to its receptors. So that are called ARBs. We will discuss, even in today's case it is there, losartans. All of them they are sartans, not shetans. So sartans are used by this way. They are now replacing mostly the pills. We will discuss that. Okay, peripheral sympathetic receptors are constrictors and dilators. Alpha 1 blockers and beta blockers. Alpha 1, where they are mostly found, alpha 1 in the heart or in the blood vessels. Alpha 1.
The blood vessels.
Blood vessels, very good. Alpha 1 mostly they are in the blood vessels. So you will see they act in the blood vessels, they will block alpha 1 receptors and they will reduce the blood pressure. The other group that will, as we already discussed, they will block beta 1 and beta 2 receptors. And when we block beta 1 and beta 2 receptors, it means we block adrenaline and noradrenaline to attach to its receptors. The last group here, that is CNS and locally acting. Centrally acting, as we already discussed here, centrally acting adrenergics. They will act in the CNS, they will increase the adrenaline in the CNS, but block to go down. So by this way, they will reduce the sympathetic activity. But what I told, mostly we don't use because it causes drowsiness. There is only one condition where the blood pressure is reversible, where the blood pressure is related with certain spatial physiological condition, and that is called pregnancy. In pregnancy, sometimes the blood pressure goes up. That is called pregnancy-associated hypertension. And pregnancy-associated hypertension is many times reversible. Why? Because pregnancy is for specific period, 9 months. 9 months, pregnancy finished, the blood pressure also comes down. So in that case, we use centrally acting, even if the patient feels drowsy, no problem, because we know this is for certain period. But in other cases where the patient needs to use it for longer duration, it may not be feasible. First thing. Secondly, it may not be able to control the blood pressure effectively. Okay? So for this reason, we don't use them regularly. I think we stop here. Inshallah, next week we will continue with our discussion. Any question for today's? Inshallah, coming slides will be easy. Why? Because we have taken diuretics, beta blockers, calcium channel blockers, ACE inhibitors, briefly. So it will help us to finish quickly. Any question? Yes.
You said that the pressure might be different from R to R.
Yeah, there is possibility.
That is possible to be like stage 2 hypertension in the right arm and.
No, not to be stages. When it comes to the stages, then normally it doesn't make big difference. But initially, similarly, like you have diabetic patients, even with position, when the patient is sitting, the blood pressure is different. The patient is standing, the blood pressure is different. The patient is lying, but that is related with comorbidity. But when it comes to something serious, when the patient is stage 2, stage 3, there I don't think, but still, even if there is 10 millimeter difference from the left to the right, it is acceptable. Why? Because we have heart on the left side and the left ventricle pumps the blood. So there is possibility and that is acceptable. Mostly no big difference, but even if there is difference, we accept it, okay, because this is left. But when it goes what we say resistant or high blood pressure, there it doesn't make difference. Clear?